So I'm glad you
Yeah.
could join.
No, definitely. So it's always easier to present a fresh case. So this is a lady I saw just about a little over a week ago. Um, it's an evaluation for heart failure in a woman that's having ongoing treatment for breast cancer. So we'll kind of piece together the case a little bit as I had to. So the consult was for cardiomyopathy. She was a 43-year-old woman, advanced breast cancer. She was hormone positive, HER2 negative, her primary was. And then she had distant liver and ovarian metastases that were HER2 positive. Her most recent evaluation of her LV showed that she had an EF about, a little borderline, EF 55%. That was on her most recent echo in May of 2012, and MUGA in March of this year with an EF of 52%. Currently, she was on Herceptin, and those are the dates. She started in 2010, took it for about 2 years, had a break, which I'm not clear why, and then she was restarted about a year ago. She's been on continued aromatase inhibitor. So I saw her because her oncologist told me she was admitted 10 days prior to an hospital with class 4 heart failure symptoms, and just a piece of paper, very brief discharge evaluation, just saying her EF at the time was 10% and she had normal chambers. She was in the CCU for a few days. She needed some inotrope-assisted diuresis, and she was discharged on a little bit of a heart failure regimen, low-dose ACE beta blocker and diuretic. Her significant history, those are her meds, and enalapril, metoprolol, Lasix BID. She's from West Africa, but no other cardiac history. So that's kind of how it started. We'll go through a little bit more about her cardiac history and her cancer history. So she had right breast DCIS in 2001. She had a right mastectomy, axillary dissection. It appeared local. She had the standard treatment, AC, 4 cycles, followed by Taxotere. She was on Lupron and tamoxifen. And then she was found to have distant metastases in November of 2009. And just around that time, she was started on trastuzumab and Arimidex. Her cardiac eval, upon initial presentation to oncology, the oncologist here saw her as soon as she became stage 4. She was managed somewhere else, I think she lived in Ohio previously. So this was her baseline EKG. Really not too remarkable. Maybe some LVH if anybody sees anything else.
No, that seems pretty close to normal. Other
Pretty
than
normal,
that,
right? Her X-ray also initially pretty normal. So unremarkable X-ray.
did she ever get any radiation?
I was trying to track that down. I didn't see it. I talked to the oncologist. He said there was some report that he got from Ohio that he had some axillary radiation, but that's a question that I don't have an answer to at this point.
This is impressive. You got a MUGA.
Yeah. So she was followed exclusively by oncology. So this was her initial MUGA in August of 2010. Her EF was 57%. And this was her baseline echo. Maybe I'll just show a few clips. Are these clips running for you guys?
Yeah, that's beautiful.
Okay, so I'll show a few clips and then maybe...
Her mitral valve looks a little thick there. I don't know.
It does, right?
Yeah.
Show you some more.
So this one is from 2010.
Yeah, this is her baseline. Pretty much, cheap stuff from the mitral valve, though it's thickened, just maybe trace MR, and it looked like her diastology and everything seemed pretty normal.
Yeah.
Anything else? Anybody wants to comment on that? Probably not.
No, that's That's
pretty normal, right? So she
good
was
image.
followed by oncology. All her cardiac monitoring was followed by oncology. She had very frequent MUGAs. I mean, basically every 3 months on treatment, and one on treatment echo. I'm actually surprised that they were doing MUGAs that frequently. So this was 2 years after her first echo. So 2 years on trastuzumab, about a year ago, almost to the date. So there's your short. So the first echo, the EF, they said was about 59%, plus minus. I guess it did biplane Simpsons on it. Any comment on her function now?
Yeah, I mean, I don't know what the measurement there is, but it might be slightly less than it was, but that's just eyeball measurements.
Yeah, and that's exactly what they said. They said EF, again, they calculated out. It was about 55. They said 52%. Looking at the diastology, maybe a little pseudo-normal, if we can take these as good readings.
Yeah, the E and A are still normal, but the E prime looks a little less, actually quite a bit less than it was. Because you had previously your E prime was almost 10.
Exactly. So, and this was her most recent MUGA. In March of this year, not much of a significant change. Went down a little bit, 52%.
So what do you think about that E prime change? Do you think that's an early marker of LV dysfunction?
I think so, actually. As I was piecing this together, I think it kind of fits together with maybe, now we're starting to catch up. We're seeing a little bit of a drop in EF on the MUGA, but I think a little bit of her, her diastolic dysfunction is showing. I think she's, having a tendency towards going into, or maybe she's more at risk now for developing something more severe.
Yeah, because, I would say this is really a beautiful case, what you've got so far. The EF is not significantly changed. It went from 55 to 52, right. So, by anybody's parameter, whether you pick an older one or a more recent one, an EF change of 3 is not significant.
And now there are no strain images, which I guess in the last, I'd say 6 months, it's been pretty standard now to do strain on some of these cases in 3D echo. But on these echoes, none of that was performed.
Yeah, I don't know if a few webinars ago we had Dr. Bonch from MD Anderson talked about using strain imaging and showed some examples and discussed how they sort of integrate that into their daily activities. We do not do that, unfortunately. I can't really, make that happen. And, part of that is because although the strain imaging per se is not, it only requires another minute or so of acquisition. It's limited right now to the type of machine that you have.
Right.
And then, for us, you have to acquire it. You can't go back and get it post-processing.
Exactly. Yeah. Now,
hey, Dan?
Yeah.
We recently tested the Philips equipment here with the new strain package that they have, and we found that was equivalent to the GE. That's the first time we found anybody equivalent to GE. So, Dan, if you have Philips, you can upgrade to their new package is one thing. The other thing is the MUGA, which is sort of traditional for the oncologist, because I guess its availability in nuclear medicine. It's plus or minus 7% on the ejection fraction. So this is within the, this is, yeah, so this is within that limit of accuracy, so it would essentially be no change.
And clinically, apparently she was doing okay. I mean, if she was followed by a cardiologist at this point, we can discuss as the case progresses, would you even think about medication up front in this somebody who has borderline function or we'll maybe address that later. So she
I think just, in somebody who, so one of the ways that we try to interact with our breast oncologists is that, we tell them any patient that you're about to start on anthracyclines or trastuzumab or any other sort of higher risk medication, we'd like to see them, and we would be happy to do essentially a pre-chemo assessment. And in that situation, if I was to see this patient, I don't know if she was hypertensive at all at that point, but if I had those two E' measurements and the knowledge that she had already gotten anthracyclines and Herceptin for a year, then I would have said, yes, I probably would have put her on something. And also I would have done biomarkers at that point to see if there's any early abnormality.
Say, Dan, on the patients that you see pre-cardiotoxic chemotherapy who have hypertension, would you switch their medications to an ACE or beta blocker if they're on some antihypertensive regimens such as HCTZ or an ARB or so forth?
Yeah, I would totally. I think using, I mean, of course I'm biased just because from a heart failure point of view, I think carvedilol is the best drug we've ever had, but so, if you just take that sort of general bias out of the picture, that would be the direction that I would go towards. Whether it be an ACE inhibitor or a certain type of beta blocker, you could, if somebody was on an ARB, I probably wouldn't change that, but if they were on hydrochlorothiazide, I definitely would.
So she came into her oncologist in the beginning of April with a persistent cough. At that time, oncologist did an x-ray and sent off some labs, and this is her x-ray if anyone wants to take a stab at it.
Yeah, I mean, her left atrium is large now, and she has splaying of her bronchus there on the left. And then she sort of has this vague infiltrate. I don't know, did she have implants? I guess she did.
She had a right mastectomy and not an implant.
No implant? Because you sort of get a sense that there's kind of an infiltrate over on the right there. Or at least that's what I see. I don't know if you agree.
Yeah, once you put them side to side, her baseline and the new one, I got a sense, I mean, this is probably overreading it, but it looked like the silhouette was a little larger. There's a little congestion. Maybe there's an infiltrate also.
Yeah, I mean, when you put them side by side, I think I would agree with what you said, absolutely.
And the atrial size, right? It's just heart's hanging a little differently and it looks a little bit enlarged.
Yeah, and I mean you can see the left bronchus is splayed where it wasn't before.
Right. So at this point, not much action was taken actually. They didn't send off biomarkers. They just did basic labs, and I'll show you that when I send some labs. She went home and...
Did they do an echo or a MUGA at that point?
Nothing. So that was April 5th. And then about 10 days later, she goes to her local county hospital in heart failure, pretty profound heart failure. So again, class 4 symptoms, she describes really, as I said, profound orthopnea and this cough, and she went directly to the CCU. She got dopamine and Lasix, and I've yet to get the films and an official report, unfortunately, but it was an EF of 10% and, again, normal dimensions, and she transitioned pretty well out of the unit, it sounded like, and was discharged on this regimen. So I'll take you. So then I see her about 4 days after discharge. You know, she said she felt better, but she still had pretty exertional dyspnea. She was orthopnic and still had this cough, and this was, these are her vitals. She's a really thin lady. She was basically coughing throughout the exam, but didn't seem that much distress, except for probably the coughing. She had elevated jugular distension. Surprisingly, had pretty clear lungs, but she had an S3, and she had pretty significant systolic murmur at the apex, radiating to the axilla. You could palpate a pulsatile liver. She was warm and didn't have any peripheral edema.
That murmur was a new finding?
You know, I haven't seen it documented anywhere, but, you know, it was the first time I saw her.
Yeah.
Was that, you think, a lisinopril cough since her chest was clear?
Yeah, you know, I definitely wasn't sure. I thought about it, but because she was, again, right, just started on the ACE about 4 days or 5 days prior.
I mean, she had evidence of what looked like pulmonary edema, so I think I would probably not throw in the towel on an ACE inhibitor at this point.
No, I kept her on it. And this was her EKG in the office.
Yeah, I mean, she's almost got a left bundle now. That's probably indicative of a, you know, diffuse cardiomyopathy.
Yeah, that's exactly right. You know, basically almost pure. It was like an IBCD, pretty almost a left bundle-like appearance. You know, I think, and she was, in, you know, base here looks like almost sinus tach. So let me get some more information. Anybody else see anything else of?
Or left atrial enlargement, but I mean that all goes with the left atypical left bundle.
Maybe some low voltage in the limb leads, but has pretty good voltage in the precordial leads there. So this was her lab work. Looked like got a little bumpy. Again, I didn't have labs, unfortunately, from the county hospital, which they're apparently somebody said that they received, so I should see it actually today. Creatinine was up a little bit as compared to her baseline. Her LFTs were elevated, and you can see that even on that evaluation in the beginning of April when she had that X-ray, she also had a little elevation. You know,
so she had some liver mets back in 2009, right?
Right, but you know, in January of this year, her LFTs were pretty normal. So initially, I thought this was either it's exactly progression of disease, or maybe this was a little congestive picture. Hard to say, but the timing kind of fit probably her volume status.
Mm-hmm.
Together with a little bump in her creatinine. Troponin was negative and BNP was through the roof there.
Yeah. Yeah. there's a not very pretty echo.
No, right? So that was her echo.
Wow, that's a lot of MR now.
A lot. And you get this sense that, because of the chamber, it was enlarged a little bit, but you can see the leaflets are pretty tethered. It looks like, and somebody commented that as we talked before, that valve. Somebody's comment was looks a little bit early rheumatic. It was just thick. I thought it was more myxomatous, like just redundant tissue, but looked maybe early rheumatic. She is from West Africa, but pretty impressive MR.
Yeah, I sort of see what you're talking about, that it kind of, almost has that little hockey stick appearance. But, the echo 2 years ago, although it was thickened, it didn't really look like rheumatic fever at that point.
No, and, I wouldn't imagine I would progress. But maybe just the apparatus just wasn't too normal to start with, but functioned fine with, near normal LV function, and once the function deteriorated, maybe the ability of it.
She didn't have any vegetation or anything that made him think of.
No, and I asked her about whether she had any, prodrome, if we're missing something here, if, she could have had something viral. I mean, common things being common, this probably was just her septin, but we can talk about. I didn't get anything else from her history. This was her inflow. The E is probably, I thought it was going to be more of a restrictive picture. All that E is probably from her MR, but her E prime, for whatever it's worth, looked actually okay here.
Yeah, but probably that's related to the MR.
Yeah, exactly.
And you just have a very significant AV gradient at the beginning of diastole.
So at that time, actually ACE I didn't double. That happened later. So I doubled her diuretic dose. I talked to her on the phone, and her cough went away. She's coming in to see me tomorrow. The EF that they calculated here was about 20%, and she's coming in with a disc from the county hospital of her echo during that admission.
So would you consider switching her to carvedilol from metoprolol?
Yeah, that's a good question. Yeah, that's a good point. I think she had blood pressure to work with, as you saw. When I saw her there, she was about 130s over 80s. I didn't up-titrate anything, as she was probably in the thralls of still a heart failure syndrome, but I think now it sounds like she's pretty stabilized, and that's a good point. I'll probably think to switch over. What do you think, Dan? What would you do then?
Yeah, I would too. I mean, I would,
Yeah.
just because, you have a comparison between metoprolol short-acting and carvedilol, and there's, clear benefit in the case of carvedilol. And then also, this is a person that you have recent class 4 heart failure. So, I mean, this fits the Copernicus study. And, in the Copernicus trial, I mean, it only took 17 patients
Number needed to treat there.
Yeah. So I think, yeah, I would do that. But then the other is, if you're having any issue with potassium, I would certainly consider adding spironolactone in this situation.
That's something. Have you had any pushback with that? There's some strange, from oncology, I guess some of the hormone conversion issues.
Yeah, I've heard people talk about that, but
yeah, it seems more theoretical than actual.
Yeah, I mean, I think it is all theory. I don't know of any piece of clinical evidence that actually worries about that. But and then it's funny, there's a couple of oncologists that I work with that when the patients are getting Taxol and they have some diffuse edema, they preferentially put them on spironolactone.
Huh.
And, I have no idea why they're doing that. It's not because they have heart failure, they have normal EF and their blood pressure is well controlled, but they have some edema, presumably because of the Taxol. And, to manage the edema, they like to use spironolactone, and I really have no reason for that. I don't know why they do that, but I don't fight it.
Have you all integrated galectin-3 into some useful algorithm for checking out patients with CHF?
We've been testing the water on galectin-3. In the case of detecting cardiac toxicity, I'm not sure that you're going to find anything there, but I don't know. And then in terms of severe heart failure, we are sort of getting our feet wet in terms of understanding what kind of information the galectin-3 adds to the picture.
Yeah, it's certainly a precursor to the aldosterone cascade, as well as fibroblast stimulation and fibrosis of the heart and so forth. And seems like if you had a high galectin-3, you might be more want to use spironolactone. And of course, we're worried about the substrate for atrial fibrillation in this patient, and the substrate has been shown by the DCAF study to be atrial fibrosis. And so we'd like to inhibit that because the next step in this patient is the development of atrial fibrillation.
Right.
I think that's a good point. I mean, it's certainly consideration in this patient that if you're thinking about biomarkers, that it might be a useful test.
So I just put a couple slides at the end, and there were just, I think, some additional questions that I just jotted down at the end. It's no surprise that over the years, there's more adjuvant chemo, more biologics, together with trastuzumab and anthracycline combos. When you look back at the larger trials, a lot of patients are on Herceptin. It seems like at least a quarter of the breast cancers overexpress HER2/neu. And in these larger trials, severe class 3, 4, runs the gamut. Also, that's easier when we can get good symptoms. And, as we talked about before, how are we going to define a significant, what does cardiotoxicity mean for a medication? Here is pretty obvious, but it can be up to, I guess, 4% of patients getting Herceptin could have like high class.
Yeah, I mean, and that's bad. I mean, 4% of people with class 3 or 4 heart failure. I mean, that's a not a good thing. But the if you look at, there was a paper by Dr. Slayman, I think like in December of 2011 in the New England Journal. It was a big study of, I don't remember what the name of it was, but big study of Herceptin and anthracyclines and the combination. And in that, there was they reported only about 2.1% of severe heart failure, but there was 19% of significant EF change of greater than 10%. And so, I mean, that's pretty high, 19%. Now,
we're talking about the numbers of patients who are on.
Yeah, and in that population, that is just an EF diagnosis,
Right.
basically.
Right.
So I think that the worrisome part about cardiac dysfunction is that you don't want it to get to the class 3 or 4 heart failure. I mean, because we know from all of our heart failure studies how bad that prognosis is.
Yeah, and you could see from this case, had a pretty, there was some presentation on, a couple weeks before. Could you have averted, well, one thing I didn't mention, so she was seen on April 5th with, looks like early heart failure. She's still got one more dose of Herceptin on April 13th, which was, 4 days prior to her.
I'm sure that didn't help.
Yeah.
But I mean, I think that this is really a beautiful case. I think I commend you for coming up with this. I mean, I think that in May of 2012, somebody who was looking at things carefully might have been able to say, we got something to worry about right now. And then, but it definitely April 5th, you had
evidence.
You had pretty significant evidence of heart failure right there.
Right. So these were just some of the things that I think we've already talked about. One thing I haven't looked at, is there, based on racial differences, are there increased risk for trastuzumab toxicity? Is there any data on
there's a little bit, and actually it's from one of the papers that you just flashed by.
From the Medicare database.
Yeah, there's another paper came out about the same time.
Okay.
It's published in the Journal of NCI.
Okay.
And who's the first author? I'll think of it sometime. Anyway, it was like in December. It was almost an identical look at patients that got treated for a variety of chemotherapies for breast cancer, and they followed them for about 5 years. And in that manuscript, there is some discussion about racial differences. I don't think it's huge, but I think that perhaps the African Americans are not treated as aggressively, but they have a slightly higher incidence of toxicity, I believe, if I remember correctly.
This is Sam from Diagnosoft, and you might want to check out, there's a study called the MESA study.
Oh, yeah.
That was done at Johns Hopkins using our software. It's called the multi-ethnic study of atherosclerosis, and basically they studied it in different racial populations. It's a huge study, multi-center. So.
Yeah, because actually there's a core of people here that are MESA too.
Okay, great.
Didn't know if they've looked at effects with different chemo regimens and cardiotoxic.
I don't think it specifically looked at cardiotoxicity, but Dr. Joel Lima is the person that runs that. But it's definitely worth taking a look at because it's basically looking at subclinical cardiovascular disease, and we can, with our software, we can detect changes before there's any changes in the EF, because basically by the time you see changes in EF, the heart's been compensating, but we can see strain changes well before that.
Dan, is there any reason to exclude coronary artery disease in this patient as part of the evaluation of decompensation of the left ventricle?
This came up, Greg, who I work with, he initially said maybe you should evaluate coronary disease. I didn't think too much of it up front. It could be, but really not much of a risk profile. 43-year-old woman, had a normal baseline EKG.
I'd probably vote to at least run it across your mind.
Yeah.
But the other thing, so for somebody who's kind of percolating along and they're doing all right, and then they suddenly change, I mean, for me, the two biggest players in terms of sudden change in EF other than chemo would be, an infection or ischemia. So
right.
If you don't really feel like there was any indicator of early sepsis or anything like that in this patient, then you probably don't need to do anything different about that.
Right. You're right. Something to think about for sure.
I mean, especially just in somebody who had such a significant change in their cardiac function, then and then with this pretty severe MR, as we talked, I would at least run endocarditis through your head.
Yeah, definitely.
But, and I think in this patient, I don't know if she had like some sort of long-term line that could be infected or something like that. But
there's a new test for evaluating a chemicals test. That's actually a gene expression test called the ICOS CAD. That's made by CardioDX. That's basically used for triaging patients with stable chest pain. That uses 23 gene expression markers to basically evaluate for underlying coronary artery disease and come up with a probability. Although that's would be innovative, that would be certainly a rough screen that you could do, because anybody who had coronary disease who developed congestive heart failure and severe mitral regurgitation would be bound to have some inflammatory markers.
Right. I mean, could be an ideal case, if I thought more about maybe even a coronary CTA. She seems like she's in a lower risk profile. Like, I don't think she would have a lot of calcium to obstruct lumen view. Could be something just to see if we're looking at obstructive disease. Her drop in EF seemed pretty global. It didn't seem like it correlated with the territory, but definitely for like a myocarditis type of picture, you have to keep that in mind.
Yeah, I don't know if anybody has been doing much in the way of cardiac MR for looking at edema and fibrosis in these patients, and as a substrate, knowing that fibrosis can be assessed with T1 imaging or edema with T2W, and that you could figure out, if it's fibrosis, it may not be as reversible as if it were edema, and so that would be interesting in this patient. That's what we do all the time with patients with myocarditis, but we don't have any experience with patients with chemotherapeutic cardiac toxicity. Does anybody have any comments about that?
There was a paper recently published, I forgot where I saw it, looking at individuals who received adriamycin that had a drop in EF, and I guess long term they did cardiac MRs and they found no increase. I forget if it was in New England or Jack. They found that there was no fibrosis in at least adriamycin-induced cardiomyopathy based on MR.
Yeah, there was a paper from Jack like in 2011 or 2012, and I know one of the authors is Davinder Jassal. I think that's how you pronounce his last name. And he presented some MRI findings in people who got primarily Herceptin. Now, whether they may have also gotten anthracyclines, but there's some suggestion that you see this small sliver of hyperenhancement in the lateral wall in people that have early evidence of cardiac toxicity. So, I mean, there's some data out there.
Got it. And the timing, I guess we talked about that. Maga, I mean, if you guys, we're trying to improve our kind of patient flow to see these guys earlier, which is probably going to be the case. We touched on maybe starting them on a medication a little bit early when we saw that she had some diabetes.
I think if you have any excuse to put them on a ACE or a beta blocker early on, that's if they're mildly hypertensive or tachycardic, then if you have a reason to do it, then I would definitely do it.
And oncology uses MUGAs.
I mean, my brain shuts off whenever you start talking about MUGAs. So
tell me about it.
I think we need to go smash the MUGA machine over there, and we like 3D echo as being much more accurate, and we like 3D MRI being the gold standard. So we need to pull the plug.
Yeah, no, and I mean, I again commend you for coming up with those MUGA images, but talk about,
I know.
I think those are best read, after you've had a couple of shots of Jack Daniels or something.
Would you ever re-challenge this patient?
Yeah, I would if
she gets better.
Yeah, if she got better, if you got her on appropriate heart failure medicine and she stabilized, and say her EF got into the 40s, if the oncologist then told you, look, she's going to die of metastatic breast cancer, and the only drug that we have that seems to have shown any benefit for this patient is Herceptin, I would consider doing it, yeah. Definitely.
Yeah, because that's, I think, what's going to happen going forward. The oncologist was telling me, she was doing so well on Herceptin. Obviously, we have to wait for her function to get better if it does. What kind of time frame do we see normally?
It depends. It depends on how bad the injury is, because, in this patient, the injury got pretty bad. And so I'd probably say you're going to need at least a couple of months to make sure that she is tolerating medicines well, and hopefully her EF will improve. So you're probably gonna have to buy a couple of months at least.
Yeah, that's what I figured. Great.
Wow, it's a super case. Thank you for doing that.
No, you're welcome. My pleasure. It's very helpful.
So, Eric, did you want to tell us about your protocol that you had?
Yeah, hold on just a minute, and we'll switch over presenters. Boom. Eric. We're switching over and putting the slide up. And basically, this is from Tom Marwick, who was at Cleveland Clinic, and he's moved over to, I don't know what his roots are, but he's at the Royal Hobart Hospital in Hobart, Australia, which is the University of Tasman. So that's kind of interesting.
I think that's where he started from.
Oh, okay. So he's made full circle. So Dr. Plana is at Cleveland Clinic, and he was at MD Anderson prior to that. And now we have Dr. Bunch at MD Anderson, who was actually from the Tampa area and was one of my students in cardiac CT. We've had a problem here with our image of our slide, and we'll see what happened to it. Where happened to it? But anyway, the story is that GE would like to put together a multi-center international study of patients who are getting anthracycline and Herceptin, and randomize them to strain and not strain echo, and do a comparison. And so Dr. Marwick has come up with this, and the people from GE are in support of this, but it's not a funded study. And so it would be limited to 20 patients in each center, which is easily doable in a short period of time. So it should be a short study, but they do want us to study them for 2 years. And so we have a protocol and a synopsis of the protocol, and then a couple slides lifted from the protocol, and we're going to get back to these slides. But it's pretty basic program, and we're just flipping through one of my presentations to the Florida cancer specialist, where we're going to, and there's we just passed your slide, Dan, and we'll be here we go. Proposal 1: 20 patients in each center with increased risk of cardiac toxicity. And this is for centers that are not totally committed to strain imaging. And I don't think anybody's really totally committed to strain imaging yet, and I don't believe that there's a firm belief that we proved that strain imaging can predict. It seems like there's a tendency, or there are thoughts that it predicts cardiac toxicity prior to drop in ejection fraction. And so if you're amenable to not using strain and not fully committed, then we could do the randomized trial with patients that would get EF alone and patients that would get strain, and then we're going to compare the two. And of course, if they have a abnormal strain, they'll go on a beta blocker and an ACE, and if they have a drop in ejection fraction, they would go on a beta blocker and their ACE, and then we're basically going to follow them. And of course, the 10% drop is what they consider, I guess, diagnostic, or one of the criteria anyway. 10% drop without symptoms in ejection fraction by echo, and a 5% drop with symptoms on echo. And of course, you'd have to do 3D echoes because the 2D echo is not accurate enough to find a 5% drop. So, and then observing for 24 months with someone following up on them frequently. That's basically the program, although there's and these are the clinics that had volunteered to be part of that program, and people that you're familiar with. And so that's kind of our plan. And if anybody else is interested, I'm sure Dr. Marwick would certainly welcome other collaborators, and certainly with GE. So it's a good way to get started, I think, doing strain imaging with this technology and learning this technology and becoming more familiar with it. So I was happy about that. And then the next thing was I was coming up with a proposal to go beyond that. And we have a group called the Florida Cancer Center Cancer Specialists, which, as you can see from this slide, there's a whole bunch of them bunched around Tampa. This is the largest private cancer group oncologist in the United States. And you can see that there's a cluster near Tampa where I am, and then there are centers that go down the coast to Fort Myers, Cape Coral. There's some over here, all the way up to Gainesville, and over on the I-4 corridor, and then up in Tallahassee, and who knows, they may cross the border into Georgia, but so far haven't jumped the border. And so we were thinking we would take advantage of this and use the local clinics as on our pilot project as the case group, and then use the clinics that are scattered that we really can't access very easily with our technology, use those for a non-strain control group using basically what would be called standard of care. And so that's how we would go on beyond this study to include more individuals. So that's kind of the proposal. That if anybody's interested in seeing the, I guess, executive summary, I'll be glad to send that to them. And then I've got the total proposal as well.
Yeah, well, we would definitely want to contribute to that. I think we're seeing these patients, and we are variably doing strain. And I think that if I could get that into our sort of the daily lexicon, that would be better. And this would be a method to do that.
Yeah, I think it's a good way to get started. And so we want to do that. And since this is 20 patients and then just observations for 24 months, so it's an entry of these 10 patients. And so that's why I wanted to continue it on, because then that gives me more opportunity to continue to have a large observation of patients with strain imaging, which I really want to get my feet wet. And of course, we are also very interested in the Diagnosoft software that Sam Lee has, that because Jose said that he can only get a good strain image on 70% of the patients, And so that leaves 30% hanging out there, and certainly using the sync protocol with sync software with MRI, you can get virtually 100%, and with sync you only use one heartbeat. So we're hoping someday to segue into that if we can get some financial sponsorship.
Yeah, I think it's a great start. Are you guys going to have a core lab to look at that, or all the echoes? They're going to have their protocol, and is there going to be maybe a core lab to evaluate all the images, or?
Well, it's definitely a very comprehensive protocol by Dr. Marwick for producing these images, and I don't recall if there was a core lab or not, but I'd be glad to send you the executive summary for your review. I think we all ought to be jumping in on this, though.
Yeah, we'd be happy to join and help.
No, definitely. I think it's really interesting, and obviously all the people that you have listed there are people that have demonstrated interest in this area.
And they all have core labs for sure.
Yeah, we'll have to look and see on the international centers if we've got, our sort of sister ICOS center over there in Milan, if they're part of that or if they'd like to be a part of that. And it seems like they haven't been able to attend this conference much. The Italians seem to travel a lot in Europe, beginning their weekend on Thursday.
Well, I think that we need to reach out and get them engaged again. We certainly want to have them involved. So this is an opportunity to do that.
Yeah, I've invited them to every meeting we've had. It seems like it's 3 o'clock in the afternoon when we begin our conference, and so it's bye to other travels where I guess they're giving lectures on Fridays.
I don't know. I will try to ask him again. So, no, this has been really great. I appreciate all of what you guys have done today. This is excellent. And we will reconvene next June. Let's see, what date is that? June 11th. Or no, sorry, June 13th. Would be our next webinar.
Yeah, we'd like to solicit more cases, and as you can see from our plans here, that we should be able to contribute quite a few cases in the future, but right now we're just building a program, so it wasn't until I met Dan and Danielle Cardinale last September that I understood the need for this program in our area, and so we should have a nice little caseload pretty soon.
Yep. No, I think we'll try to get some other interesting things. See if we can get some more people to contribute.
Great. Well, you're very good at twisting arms, Dan. So you stay out there and keep twisting, okay?
All right. Sounds
Thanks
good.
for having me, Dan.
Thank you very much, Double Dans.
All right. See you guys later.
All the best.
Thanks.